السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. نكمل مجموعة الحلقات عن الاسترويد kidney transplant, steroid in general, and we'll continue our talk today. What is the precaution about the steroid and the kidney transplant, pre-transplant consideration. Don't forget before starting steroid for any nephrology case, either transplant or other disease. Don't forget the infection screen, especially if not emergency. Just don't forget the latent infection should be considered before proceeding for any immunosuppression therapy, depending on the urgency and the timing of immunosuppression. Don't forget latent tuberculosis. Don't forget to do TB skin test or interferon gamma release assay, blood test if you think your patient have or in endemic area for tuberculosis. Rule out active TB symptoms, chest X-ray, sputum testing. You should start treatment for months, either rifampicin or 9 months isoniazid plus pyridoxine vitamin B6. Syphilis, hepatitis B, C, HIV, especially if chronic ill patient. Don't forget in transplant patient, especially in transplant workup from endemic area, strongyloidosis from endemic area, Africa, Asia, South Asia, and Central and South America. And this only treatment is easily just 2 tablet ivermectin, and after 1 week or 2 weeks, just repeat another 2 tablet or 4 tablet. This easy treatment for this bacteria, for this parasites. But if this parasite missed, and if you will see one case missed and given immunosuppression, you will see horrible outcome for your transplant. Just you can suspect this from your CBC during the admission for kidney transplant surgery. If you will see persistent peripheral unexplained eosinophilia, just put in your mind to send the stool examination and the blood also for strongylosis plus schistosomiasis to rule out these two parasites. Immunization. Immune response to vaccine may be inadequate in immunocompromised patient. Individuals who are fully immunized may remain at risk for vaccine preventable disease. Delay vaccination if immunodeficiency is transient. If serological testing available and there is clear antibody correlate with protection, measurement of post-immunization antibody titer to determine immune response and guide revaccination. If your patient is still not immune, you can give more booster until your patient get immunity. Vaccinate family and the caregiver as possible. Don't forget the invasive pneumococcal vaccines and Haemophilus influenza vaccine. Influenza vaccine should be annually for all your patient post-transplant. COVID vaccine every 6 months post-transplant, and he should receive his doses of vaccine already and the booster before transplant. Hepatitis B vaccination should be hepatitis B immune above 100. Not only just above 10, like normal population should be above 100 for hepatitis B vaccination, and you should give your patient, any patient on dialysis, he should be hepatitis B immunized. Hepatitis B surface antibody should be above 100 during dialysis while you are working for kidney transplant workup for your patient. For varicella, if you have one patient with varicella zoster virus IgG negative, he should receive 1 dose. They mention 2 months apart. Now they mention 3 months apart, and after this just only 2 doses. And this, after the second dose, it should be at least 1 month before transplant surgery. Don't forget. And we have now this Shingrix. This is not live vaccine because varicella zoster is a live vaccine used before transplant surgery, but after transplant surgery, you can use Shingrix after your patient in lower immunization or immunosuppression medication. Vaccination with live vaccine, measles contraindicated, mumps contraindicated, rubella, MMR contraindicated post-transplant, live varicella contraindicated post-transplant, rotavirus, yellow fever, all this contraindicated post-transplant. And no one should use this medication after transplant. Live virus vaccine can be administered to patients who are receiving steroid therapy when administration is short term, less than 14 days only, low to moderate dose, less than 20 milligram, but better to avoid. long term alternate treatment. Short, be careful, because if you will get measles or mumps or rubella after transplant, it will be horrible disease. Pneumocystis gyrophyrae, or pneumocystis cornea pneumonia prophylaxis. This already should be in a post transplant protocol already. We are giving our patient, most of our patient, on Septra, trimethoprim and sulfamethoxazole, if not allergy. And some center just giving for 1 year, and now Toronto General Hospital giving for forever. No stop, because they already saw horrible causes, especially post lung transplant with PCP pneumonia or PGP pneumonia, and recommended just prophylaxis in general nephrology if the prednisone continued longer time, more than 4 weeks on 20 milligram or more. And yes, for PGP prophylaxis, we can use trimethoprim methoxazole اللي هو السبترا 400 to 80 single strength tablet. عندنا في centers تديها Monday, Wednesday, Friday, or every other day. And as they mentioned, this small dose should be continued daily, especially if your creatinine and the potassium is okay. If allergy to salva, what you will do? You have another choices like Dapsone, Atuvacone, and pentamidine. Usually pentamidine 300 milligram inhaler, just once monthly, just a nebulizer. Every 4 weeks or every 1 month, you should give salbutamol in nebulizer also, around 30 minutes before the pentamidine dose. If you have this inhaler or nebulizer, it will be good for your patient. If you don't have, usually the second option I am using Atuvacone 1500 milligram BO once daily. And sometimes for this another option, you can complete just only for 6 months, 9 months, if low risk for BGB pneumonia. And Dapsone, rarely I saw already, maybe a little bit, you can see 2-3 patients a year. 100 milligram BO daily, but need to be sure his G6PD not deficient. تمام, for hemolytic anemia. وشكرا جزيلا، وإن شاء الله يا رب تكونوا استفدتوا معلومة، ونسأل الله أن يكون علم ينتفع به الجميع، ونسألكم الدعاء والتوفيق والسداد. ونلتقي المحاضرة القادمة، هنبدأ إن شاء الله بالسي اي، وبعد كده الام ام اف، ونشوفوا الحاجات اللي بعديهم السيرولوماس والحاجات التانية اللي موتورز والازاسيوبرين والكلام ده كله، نجمعهم مع بعض إن شاء الله في محاضرات منفصلة، في حلقات قصيرة بإذن الله. أنا أترككم في رعاية الله وحفظه، ولا تنسونا من صالح الدعاء. والسلام عليكم ورحمة الله وبركاته.